Hey, welcome everyone. My name is Megan Carley, the project coordinator for the California Evidence-Based Clearinghouse for Child Welfare, or CEBC for short. I'd like to welcome you all for joining us and welcome you to the webinar. Thank you for answering the poll question. This is helpful information for our presenter. We've muted your phones due to the high number of participants attending, so if you are experiencing any technical difficulties or have any urgent questions, please use the Q&A pod that's located on the right side of the screen and we'll do our best to assist you. We will be answering any of the questions you may have at the end of the webinar, so use that same Q&A pod to send us your questions and we'll do our best to answer them. Lastly, you will receive a link shortly after the conclusion of this webinar to complete a brief survey so we can continue to improve our webinars and make them as useful and beneficial as possible in the future. Now, just a brief introduction of our presenter. Lucy Berlinger is the director of the Harborview Center for Sexual Assault and Traumatic Stress in Seattle, Washington. She is also a clinical associate professor at the University of Washington School of Social Work and Department of Psychiatry and Behavioral Sciences. Her activities include clinical practice with child and adult victims of trauma and crime, research on the impact of trauma and the effectiveness of clinical and societal interventions, and participation in local and national social policy initiatives to promote the interests of trauma and crime victims. Lucy has also served as a member of the CEBC's scientific panel since it was formed in 2005. And now I will pass it on to Lucy.
Good morning. Welcome, and great to have all of you here. And I can see that you're from a lot of different places, so I'm going to hope that what I have to say will be useful to the whole array of people trying to figure out this whole evidence-based thing. And as I know you all know, this is a follow-up to Ben Saunders' talk previously, so I'm building off of what he said. And actually, this slide could have been, I can see I should have made it a little bit different, because really what I want to talk about is evidence-informed decisions about evidence-based interventions. So I'm making an assumption that everybody on this call, we're the people who have been persuaded that evidence-based interventions are when available, the preferred choice over a non-evidence-based, and however you want to define the term evidence-based. So this is not at all a talk about, hey, aren't evidence-based interventions a good thing? It's more, okay, we're on the bus as far as evidence-based interventions goes, but now we got all these LMNOPs and a whole collection. How are decisions made in the real world about which ones to choose? So I know that Ben took you guys on a tour of a variety of possible interventions that have been tested and shown to work with child welfare populations. I added a few more to his menu here, like Triple P, Target, MST CAN, which is an adaptation of MST for child abuse and neglect situations, and Incredible Years, because these are all interventions that have had are research-based for child welfare families. So the basic principles or framework that I think those of us who are on the evidence-based bus want to have in making decisions about which interventions to choose at a variety of levels, whether it's organizational or service planning or clinical. The first question is, evidence-based interventions basically target a particular problem. They actually are only evidence-based for the problem they've got evidence for. So a program can be very well-researched and very effective for one problem, but be the wrong match for another problem. So in making these decisions, whether you're an administrator, a caseworker, a CASA, or a clinician, the first question is, what is the problem that you want to do something about, followed on by, well, what do we know that works for that problem? I think that this is an incredibly important initial decision. And then of course, there's the question of Well, evidence-based interventions, what that really means is that the research program has been compared to something else, and overall the people getting the research-based one are doing better. It does not mean that every single person who is not getting it doesn't get any benefit out of whatever it is they're getting, nor does it mean that every person who's getting the evidence-based intervention is actually receiving the benefit. So this question of measurement, or how do we know whether it's working, is one that I think I would, in my observation, that's one that we have not attended to quite as much as we have to getting on the evidence-based bus and agreeing that one ought to have them. So my view is that matching is the key to the whole deal, whatever level you're at. Now, the first course situation, I know there are a number of people who are administrators, is, well, what is the setting and what have you got on your menu? There are a lot of different settings where services are delivered that are used in child welfare, and settings do different things, have different populations they serve, have different capacities. And somewhere along the line, people make decisions about what to put on the menu in their organization. Personally, I'm getting a little bit worried about too many things on the menu, that everybody wants to be able to say, well, we have this, that, and the other evidence-based intervention. And sometimes that not only does that present problems from an organizational perspective, so how do you make sure people are trained in them? How do you do QA and supervision if you have 5 or 6 or 7 or 8 different evidence-based interventions? But it also gets kind of confusing for decision making. For example, there are lots and lots of different parenting interventions or interventions for behavior problems. And it's not unusual, from what I'm observing nowadays, is for organizations to offer 2, 3, 4, 5 different parenting interventions. And this is also reflected over on the casework service planning side, where it's not unusual to see a parent with a service plan that might have 2 or 3 different parenting interventions. That's not actually a good idea for all the obvious reasons. From the service planning side, it's somewhat of a setup for the parents to have multiple interventions that target the exact same thing. It increases the risk of failure. It dilutes the impact of the intervention itself. And from an organizational perspective, it can make it just that much more complicated to manage and oversee and make sure that the interventions you've chosen are actually being done the right way. We know we can teach people how to do it and get them competent, but we really don't have lots of knowledge yet about how do you keep all these different things going in an organizational setting. So I think it's important for organizations to really do a thoughtful job of deciding what are the interventions that are most appropriate for our setting and our population. And let's not have more than we need, because keeping them all going and being done in the best way is going to be is hard work. Now, at the individual case level, the questions are a little bit different because really what they're going to do is choose off of the menu that has been decided by the organization or is available in the community. And at the individual clinical level, family level or child level, the first question is right back to, well, what is the problem that somebody thinks this child or this family needs help with? And then we have a menu either within an organization or in a community that has a number of different evidence-based interventions available. Which are the ones that work for that problem? And then for both providers and child welfare caseworkers, how is it going to be measured whether or not people are making progress? I think we're all in agreement that this business of service plan compliance being entirely driven by attendance is really not the best way to know whether parents have gained new skills and learned what they need to learn. And so we need to make sure that we've built in, whatever the intervention is, a way to know whether it's working. So I'm going to run through a few sort of ways to think about matching from the organizational perspective, and then I'm going to talk about matching from the more individual case level perspective. As mentioned, it matters what setting you're in, what your context's in. So a CAC has a particular function and position in a community that's different perhaps than a hospital-based specialty clinic or a general community mental health center or a specialty program that targets maybe young children through an early learning or early childhood development angle. So it is very important to think about, well, what are the interventions that fit with my setting and it would be most appropriate. So I want to just give a couple of examples, and they're not meant to be definitive or exclusive, but just to illustrate the matching premise in terms of the interventions we have on our menu. So if you're a CAC, what defines a CAC and therefore should be important in making a decision about which interventions are we going to have on our menu if we're going to have psychosocial interventions? So CACs basically are primarily, or their original mission was to respond to acute situations of child abuse and neglect. Of course, everybody knows they started with sexual abuse, but now very common in a community, the Child Advocacy Center will be the go-to place at the point that a case is discovered, reported, or opened. So you have a scenario in terms of client population where most cases are acute, meaning they're recently discovered or recently happened, and they're all specifically related to trauma or child abuse. So it's a specialty context. An example of an intervention that would be a very good match for a CAC would be the Child and Family Traumatic Stress Intervention Program, which is evidence-based in the sense that it's been subject to evaluation. And it's a brief intervention designed to basically give families information about current psychological distress using measurement, by the way. There's big emphasis in that intervention on measuring psychological impact. Give some psychoed, some information about trauma and its impact and symptoms, and some coping skills. So this would be a very good match, I would think, in terms of what CACs are set up for and what this intervention is designed to do. Now, I'm in no way suggesting that's the only intervention that a CAC ought to have, only just to illustrate the principle of matching. Okay, so here's another illustration of an intervention that one might want to think about, well, where's the right place for it? So Target is a trauma-focused intervention, but it's one that doesn't primarily focus on addressing a trauma narrative like trauma-focused CBT does, but its emphasis is teaching emotion regulation and coping skills. And it's been tested with delinquents, so higher-endish kids who are mostly in residential settings, whose real problems are they're dysregulated, they're acting up, they're blowing out, they have a lot of emotion regulation problems. So if you had a program that was primarily focused on kids in that type of situation, I'd think residential settings, runaway youth settings, delinquency settings, this might be a good intervention to have on the menu because it has a very strong emphasis on teaching emotion regulation skills for use in the moment, and it looks like it's doing a pretty good job with PTSD as well. Now, here's the really complicated problem, which has to do with general public mental health centers, whatever they are in your community or your state. But this is where kids go when they have Medicaid as their insurance, and they could have anything and everything as a mental health problem. So and as everyone knows, children in foster care are automatically eligible for Medicaid-covered services. Now, the problem for a general mental health center, as you can just see, is that they are obligated to serve every kid who walks in the door, regardless of their problem. And I've been trying to add up what's the minimum number of interventions you would need to have in order to serve the broad number of kids who walk in the door, and it's probably 12 or 13. Now, if you think about that from an administrator's point of view, that's kind of a nightmare to imagine having people trained up in 13 or evidence-based interventions, supervised with monitoring and QA, et cetera. So I feel for the public mental health people who are trying very hard to have a more evidence-based service menu. Now, in terms of the population we're talking about today, children affected by abuse or trauma, it is very important for us to keep in mind that not every kid who's been exposed to abuse and trauma develops a persisting mental health condition, that only a minority of kids seeking services in public mental health are coming because of the effects of trauma and abuse. In fact, the majority of children are coming for the usual standby mental health behavioral problems kids have: ADHD, behavior problems, anxiety, mood problems. So a trauma-focused intervention is a good thing to have on the menu, but it's actually not really the only thing you want to have on a menu in a public mental health center. Now, the other problems, of course, public mental health centers have to think about is comorbidity. Most kids are comorbid, and so how do you figure out what's the thing you want to choose in an individual case? The good news being that since most kids are comorbid, a lot of evidence-based interventions work pretty well for other comorbid problems. Public mental health centers also usually have responsibility for the very high-end, super severe kinds of children who have multiple diagnoses, lots of problems, very complex circumstances for whom approaches such as wraparound are often used. Now, wraparound isn't an intervention. It's a structured process for making sure the right people are part of the planning and overseeing. But what should go on the menu for those kids? I mean, those kids have every problem, and we probably wouldn't think the best strategy is to have a service for every one of those problems. So I think public mental health is in a situation where making these decisions is a little bit more difficult than it is in a specialty setting. So the main match considerations that jump out at me in thinking about this are, well, what is your setting? Is it outpatient or residential? Are you general versus specialty? What is your population? Who do you primarily serve? What's your specialty area? And then, of course, from a clinical level, the biggest decision-making factor that are relevant in making are the problems that the child has primarily internalizing, or are they primarily externalizing? Because we do pretty different things if it's an internalizing problem versus an externalizing problem, and there's some key elements that have to be considered. If, for example, it's an externalizing problem, you've got to have a caregiver involved or the caregiving environment. Individual therapies just haven't been shown to be effective for them. And then trauma-specific versus not. So you could have a child who's had a horrible history of child abuse and neglect, but they may or may not need a trauma-specific intervention, at least not as the priority. So these are just some of the things that I think are important for decision makers, whether it's organization leaders, service planners like caseworkers in child welfare, or clinicians to consider. Now I'm going to race very quickly through and then talk a little bit more about the menu review that Ben provided for you. And I think it's a really helpful thing to have in your mind. It's a good way of making sure you get back to that original question of what is the problem, and then what do we know works for that problem, and where can we get that program? Do we have it here? Is it somewhere in our community? And that sort of thing. So you've already heard about the impact of trauma interventions, and we're very fortunate because we've got a lot of them. And of course, we have trauma-focused CBT, which is not just for post-traumatic stress, although that's a primary target. It's really for when children's problems are related directly to the trauma or the abuse in their background. And we have fabulous support for it, including some of you may have seen a recent paper published in the Journal of the American Academy of Child and Adolescent Psychiatry showing that it worked for sexually exploited girls in the Congo. But there are, as Ben had mentioned, there are some other interventions that are along the CBT lines that also have been shown to be effective as trauma-focused treatments. And these treatments, tend to do pretty well for depression and anxiety that goes along with post-traumatic stress. Then we have the group of the family of treatments for behavior problems. Now, people tend to have allegiances, the ones they like best and they prefer and they've been trained in and this, that, and the other thing. The evidence that one works better than another is not very strong. They're all based on the same principle. They all, if you look in the box, look beyond the LMNOP part, the brand name, it turns out they all teach essentially the same thing. They all teach the idea of attending to positive behavior, learning to give effective instructions, using timeout and behavioral contracting to deal with misbehavior. So we're very fortunate in that we have quite a few of them. There's not much need to get too bogged down on which one is used. I'm only familiar with one head-to-head study comparing Triple P and PCIT, and they both worked out pretty well. So this is an area where I think it's more a matter of, what is going to work for your setting. Now, some of them have little limitations or they have advantages that you might want to take into account. Like PCIT has the great advantage that the delivery vehicle involves coaching the parent to do the behavior, and you're watching it. That's a kind of a good situation for child welfare because you have data to show that parents actually are learning the skills because they're being observed, but it's only for kids 2 to 7. Triple P has some other advantages that are worth considering is they have multiple levels of intensity. Triple P has they have a community general population part, but from a clinical perspective, they have a brief focused version, primary care version, which might, in some cases, for foster parents who don't really need a whole course of PCIT or something else, but they're struggling with a particular behavior that a kid is having that's kind of a complication in their home. So the brief version of Triple P could be a very nice item to have on the menu. And of course, then they have group and individual and then the enhanced version. So knowing what the programs are and thinking about how they would match up to your population is the exercise to undertake. As I mentioned, nobody needs to have 2 parenting interventions going on at the same time. That is likely to dilute the effect of any of them. Now, the cool thing about parenting interventions or behavior problem interventions is that they are designed to improve kids' behavior problems and enhance and promote positive parenting or effective parenting. So they are probably the fallback intervention for any child welfare service plan, and they have the great advantage of addressing 2 things at one time. See, there's no need for somebody to go somewhere and get a parenting intervention and then have a child sent off somewhere else to get a behavior problem intervention. All behavior problem interventions involve caregivers, and they're based on the premise that by strengthening and enhancing the parent-child relationship, the behaviors will actually be reduced because most negative behaviors in kids persist because of ineffective parenting. So the parenting intervention, in my mind, is a really key one, and we could make more impact by really enhancing the capacity to deliver effective parenting interventions to our families. The biggest problem in terms of parenting intervention has nothing to do with whether we know what works. It really has to do with the problem we're all coming to realize, which is how do you get people to do the thing that works? But we got a good situation on that menu. We have a much smaller group, but luckily there's overlap of interventions that work when there is a concern about parental violence. So the parent has physically abused the child, is at risk to do so, has been coercive with the child, and then there probably would extend to domestic violence situations. And we have 3 interventions that generally address this problem: PCIT, AFCBT, and multisystemic therapy CAN. These are interventions that communities are PCIT is pretty widespread, but AFCBT and MST CAN have not extended very far. So when a community or an agency is thinking, what do we have to offer when a parent has beaten their kid or is very coercive with the child or is very at risk, we probably need to be beefing those up more to have more availability. And then there's some other interventions for our population that are for more specialized, less common problems like attachment problems. There's CPP, child-parent psychotherapy. There's ABC, biobehavioral catch-up for little kids that are infant mental health oriented, and then promoting first relationships is another one. There is an intervention approach for sexual behavior problems, although I will say there's no reason why general old behavior problem therapy couldn't work for sexual behavior problems. The only issue with sexual behavior problems, people are more freaked out about it. But it's CBT. So you don't need to have a whole specialized program. But we have good evidence that CBT will work for sexual behavior problems. And then Carla Danielson has a neat intervention for kids with who are these teenagers who have these other problems, who are engaging in sexually risky behavior. They got substance abuse, they got PTSD. Again, it's a combined intervention which has elements from proven interventions for each of those. It's not very widely available, but it sure would be nice to have more of it. So just to think about possibilities. So back to my main point, you got to match the program to the target that's been identified. And you got to prioritize the target. Is it behavior problems? Is it post-traumatic stress? Is it an impaired infant-child bond? And then use that as your first determinant. So that brings up the question of, well, how do you measure the target you've identified? How would you know how big the problem is, and how would you know if it's getting better? So standardized measurement is going to become the way things are done. It's not as systematic or as common yet in most settings as it will be, but if you look around into other worlds, like in healthcare, first of all, they measure things all the time. People would think it was very peculiar if they had a blood pressure problem and the doctor didn't measure their blood pressure when they came back to see if the treatment is working. There's a JCAHO requirement that you measure pain for all kids in hospitals. The PHQ-9 is everywhere. I had a funny experience just a couple weeks ago. A patient I had seen a couple years ago who wasn't ready to participate in an active treatment reappears. I give her a PHQ-9 to assess her level of depression because she talked about that on the phone, and she said, "Oh, I filled one out this morning." She had gone to her primary care doctor who had said, "I'm kind of depressed," and the primary care doctor gave her a PHQ-9. So measurement is integral to the practice of medicine. I like to think of what we do as part of the healthcare delivery system, and measurement is really something that we need to figure out how to do in a more consistent way. Now, the problem of measurement can be that there are tons and tons of measures. People are inventing them left, right, and center. There are companies that sell them. That may or may not be feasible for a community organization to buy standardized measures for every single case they have or for every session. A good example of the complication is the ECBE, the IBERG behavior checklist, which is associated with PCIT. If you did PCIT by the book, you would be giving an ECBE every single session. The problem is you have to buy the ECBE, and it costs, 50 cents, a buck every time. That's probably out of the range of what most organizations can invest in for every session. So we really want to get away from a situation where the only measures that people know about or use are the ones that cost money, because that will obviously, by definition, limit their use. So luckily, there are some free, short, reliable, and valid measures out and about. The PHQ-9 is a very good example, and that measures depression for 12 and up, and including adults. But we've made we've gone on the hunt here at our program to try to find measures that could be incorporated into routine clinical practice. So we've, the website here, you can go there and look in the CBT Plus notebook, and there's a folder called Assessment, and download them. So we have one for PTSD, one for anxiety, one for depression, one for behavior problems that parents fill out. This is a consideration that organizations probably have to put some time into, because making this standard practice is important, but it's going to take some getting used to for providers who aren't used to the idea. No way is a standardized measure intended to substitute from a good clinical assessment or a clinical interview, but it is a great way to measure how big of a problem something is. And a lot of master's level people probably didn't get training in the idea of using a standardized measure, and might have some apprehension about how clients might feel about it. But I can tell you, clients love them. They really like to know how big their problem is, because what a standardized measure is doing is comparing the respondent's level of concern to that of a whole bunch of other people. It actually can be a really terrific engagement method, as long as you're giving feedback. I mean, if somebody's handed something that they check off boxes and then no one talks to them about it, well, that's not very helpful, and people will consider it for what it is, paperwork. But a discussion about what it means, how it relates to the treatment, can be a therapeutic encounter in and of itself. We've found that it actually lowers some of people's suspicion about things like diagnosis, which for some people who have concerns about mental health, they might experience as you telling them what's wrong with them. So whereas they might be very interested to know how they stack up relative to a whole bunch of other people, it somehow makes it less of a direct judgment by the provider. So I couldn't be stronger in recommending the importance of starting to incorporate standardized measurement into routine practice, both for the providers, so that you know what is the target, what am I treating here, and for the clients to know how they're doing. And organizationally, if you can invest the IT in it, it's an excellent way to show organizational status in terms of how are we overall doing in terms of people getting better. Now, it's a little bit complicated when you've got all these different measures and all that kind of thing, but you get the idea behind it. Now, I'm just mentioning these few that are free, short, reliable, and valid. I'm not suggesting they're the only ones or the best ones. They're measures of functioning, like the CAFIS or the Colloquilis or the CANS. So there are lots of possibilities, but it's an important discussion and will help a lot. So so the next thing is not just is the deciding what your target is and therefore what treatment you're going to give, but it's a measurement, going back to what I said in the beginning of, well, how well is it working? So that means that doing an assessment and identifying a score or a target is only the first step. As you go along in treatment, the goal is going to be to measure how well is it going. Is this person benefiting? Are they getting better? And this is, again, another one of these work in progress things, because a fundamental principle of evidence-based practice is that you treat to the target, not that although most evidence-based interventions are presented as programs, meaning you deliver all of it, and then you've got a good chance of knowing that the people are going to actually do better overall. There are a few complications with that, in that lots of people don't complete therapies and do the whole program. So we don't want to be stuck with only completion of the full meal deal, because in research, in the group getting the experimental intervention, it doesn't mean that everyone didn't get better until they'd gotten all 9, 10, 12, 16, whatever the number is, sessions. Some people got better sooner. Some people got better later. So measurement over time at routine intervals is and should become a part of standard service practice. As mentioned, that's what they do in PCIT. They measure the ECBE. How are the behavior problems going, so that they can show whether they're improving. Now, the reason for doing this, of course, is to make sure you're actually on the right target. So you want to know, if people aren't getting better, why is that? Have I got the wrong clinical target? Is there some reason why the intervention isn't really working? Do we need to tweak it? Do we need to adapt it? So these are just a couple of illustrations of ways that people have come up with to measure over time. And all of these can be done, as you can see, the clinical dashboard example, that's from Hawaii, where their mental health system requires people to enter data. So having some method of repeat assessment is really going to be an important way of seeing if what you're doing is working. Now, the key, as I mentioned, it's the feedback to the client. If the client doesn't have a discussion with the provider about this, then it's not going to be very helpful or very useful. Now, these measurement over time things are also useful, not just between the individual provider and the client, but they're also useful in terms of child welfare and casework planning to know, are these people getting better? If decisions have to be made about visitation, about children moving home, cases being closed, child welfare social workers really want to know, well, how are people doing? So repeat measurement has multiple values in the child welfare system, not just clinical, but also system decision making. Now, I want to talk just a little bit about making adjustments within a model, because, as mentioned, we have all these interventions, and a developer will basically say, just do it the way it's supposed to be done, do the whole thing. And they have, every basis for taking that position, because they've proven that if you do the whole thing overall, the chances are. But in the real world, people have to make adjustments and adaptations to the delivery. That there's no, whether that's right or wrong doesn't really matter, because that's what people are going to do. So trying to figure out good ways to approach that really keep the evidence-based part going, but at the same time allow for the variations on individual cases. And that's tricky. It's not an easy way to go, but it definitely can be done. Now, I want to give an example of a paper that Judy Cohen, Tony Manarino, and I wrote, which had to do with making a few adjustments within the model of TFCBT. TFCBT is an exceptional intervention, and it's kind of funny when you think about it, because it has a part that focuses on internalizing the post-traumatic stress, depression, and anxiety. And then it has a section that focuses on behavior problems and positive parenting. Any of you who know TFCBT know they use the acronym PRACTICE for the components, and one of the P's is positive parenting. And if you're really delivering TFCBT by the book, the caregiver is going to get about 50% of the active treatment. So it's inherent to the model that the caregiver is involved and is having treatment as part of the delivery. So what we discussed in this paper was how to address the situation, which in my experience is not all that uncommon, where the child might have post-traumatic stress and depression, but what the parent is focused on is the behavior problems, the acting up, the not doing what they're told, the throwing fits, the not being willing to go to school, the behavioral part of it. So we recommended when the parent is primarily focused on the behavior problems, they're not so interested in the kid being afraid of their memories and withdrawn and sad and upset. What they're interested in is getting this kid to behave better and not be such a problem to live with in the household. But when that is the nature of the parent's concern, that you make an adjustment within the model to maybe see the parent first. So you're showing the parent you empathize with and care about the problem they're most concerned about. Focusing more on the positive parenting elements than on the psychoeducation about the impact of trauma, etc. You want to always be weaving in the link between the behavior problem and the history of abuse or trauma, but prioritizing an emphasis on helping the parent learn the skills that will reduce the behavior problems. Because if the behavior problems persist, the parent isn't going to be warm and close towards the child, something that we think is very, very important for kids who've been abused. They'll be irritated, and perhaps the relationship will be strained and conflicted. So that's an illustration of how within one model, just by when you deliver it, the priority you put on it, the focus, you're not really straying from the treatment model because you're doing it, doing the treatment, but you're prioritizing a little bit the delivery. Now, there's some other variations on this theme that are much, much more modular. Some of you have probably heard about MATCH or MAP, which is another variation on the same theme that's widely used, I believe, in LA and Hawaii, where rather than having an evidence-based intervention that's a program that targets a particular outcome and is delivered step by step, this is the mixing and matching in modules based on assessment. Now, the trouble with doing this in the real world, and by the way, there's a randomized trial showing that it actually works better than usual care, and it works better than giving sequential evidence-based treatments. And therapists like it better, and if you like it, you're probably more likely to do it. But this does require close monitoring and measurement all the time, because without that, there's a tendency to drift away from being evidence-based and focused and to end up just doing a little of this and a little of that, which we already know is not the most effective approach. So that's both an organizational decision and, well, it's very much an organizational decision because the infrastructure to manage the decision-making and do the measuring has to be in place. I think it's pretty unlikely, and I don't think the developers would believe just buying the manual and saying, okay, follow this manual would be good enough. Now, a more structured version of this is MAP, which is the Bruce Chorpita's operation, and you can buy a subscription. They do it in Hawaii for public mental health. They have to do it. People won't get paid if their clinicians aren't entering data saying which of the evidence-based modules they used and all of that. But the model can be purchased at the individual level. It's called PracticeWise, and you can get a subscription. And then by entering information about cases, the program will give the algorithm saying, well, if that's the problem, do this. So it's a very nice little setup for helping guide a clinician who wants to take a modular approach. The downside, of course, is you have to pay for it, and it's an individual subscription, so it's not always clear. Organizations have to decide whether or not they actually have the resources to do that. So my take-home message about making evidence-informed decisions about evidence-based interventions, I think I've beaten the drum pretty persistently here, which is the importance of the match principle, matching organizationally and matching at the individual case level. What intervention are we going to have on our menu, and making sure that decisions are made about matching up evidence-based interventions to the problems that people have, and not misapplying an evidence-based intervention for one problem and giving it to somebody who doesn't even have that problem. Evidence-based intervention, only evidence-based for what they're evidence-based for. And the other key, take-home message is measurement. How do you know what the problem is? How do you know how big the problem is? How do you know if the problem's getting better? And it's important both at the individual case level, possibly in the legal decision-making level, and at the aggregate level for organizations. So they're two pretty simple principles, but they're not all that simple, like so many things. They're not that simple to put into effect in real life because cases are messy and complicated, and there are often, constraints on resources. In our view, looking at the dissemination and intervention literature, one of the most important things that has to be in place is the organizational support and leadership. It's been shown that when the leaders of organizations say evidence-based, is the way we're going, and that could be at a clinical organization or a services organization, it could be in a child welfare agency, and we're going to do things within our organizational context to support and reinforce people in having the training and getting the supervision to do it the right way, and in providing them with the other kinds of supports. It's not just going to happen on its own because somebody went to a class and came back saying, well, now I know how to do this or that evidence-based intervention. So it is quite an investment, and there are going to need to be more practical strategies for organizations, because not everyone's going to be in LA where they apparently have an endless supply of money to pay for evidence-based intervention. So that is what I had to say. I know you're able to ask questions if you have any, and I'm available to answer. Okay, so there's a question about the ECBE, the IBERG, and whether or not it's required for every session, and it depends on who you ask. The PCIT International, which is Sheila IBERG's operation, that is the standard that they have set for doing PCIT by the book. But they're not, they don't tell every provider what they can and can't do. In actual clinical practice, I would say it's much more common to see people doing it at the beginning, at the end of the first section of PCIT, and then later on. And I think that's the way it's most commonly done. I know that that's the approach that's recommended by the Davis group, and they also have a non-proprietary measure for behavior problems that I believe is available to others to use. So I think that that's the point, is that most places can't afford to buy measures for 17 sessions just because an organization has said, well, that's the gold standard for doing it. The key, though, is measuring something in some way on a more than just at the beginning. There's a question about residential treatment settings, and I think that the key in thinking about residential treatment settings is that the milieu is essentially the family or the caregiving environment, and how linked in the milieu is to the specific formal treatment is incredibly important. We don't do TFCBT alone with the child and not have the parent reinforcing, supporting, knowing what's going on. And too often in residential, kids go off to their individual therapy and the milieu does whatever it does. Luckily, for example, with TFCBT, the TFCBT folks have come up with sort of a guide or an outline, and if you want to email me, I'll give it to you, about how the milieu can reinforce and support what's going on in the treatment. The biggest issues in the milieu, of course, are making sure that I think the trauma-informed perspective, making sure the staff are trained to think about kids and their problems from the perspective that what they're doing, obnoxious and irritating as it might be an adaptation or a reaction that comes out of their terrible past or their experiences, so that staff don't look on the kids as sort of an on-purpose, misbehaving just to ruin people's lives. And the second part is the basics of behavioral management. Kids have to get attention for being good. It's very common in residential environments that you're ignored if you're good, but boy, do you get to be the center of attention when you act up. So the basic behavioral management for staff, milieu staff, is really critical, with the key thing being attending and reinforcing positive behaviors and minimizing punishments and coercive behaviors. And then there are interventions that focus a little bit more on the emotion regulation side of things. As I mentioned, Target is a good example of that. And then, so that's the way I would think of it, is making sure the milieu is actually on board with evidence-based approaches, even if they're not delivering discrete evidence-based interventions. Okay, someone is asking about the circle of security. I think the circle of security doesn't have strong evidence yet to support its making a difference in child welfare outcomes. I know they had a trial here in Washington State, and while it may have improved some things about the interaction between parents and kids, it didn't affect child abuse re-referral. I would say it goes in the category of sort of the infant mental health interventions, like biobehavioral catch-up, Mary Dozier's intervention, or promoting first relationships, or CPP. They're all essentially trying to help parents become more attuned and responsive to their children. Many of them use videotape and reflection as a method of helping parents learn to do that. So I would say it's probably in that group of interventions, and that's, while it hasn't been proven to reduce child welfare outcomes, it's probably, they're all variations on a similar theme.
All right, well, we're going to